تمام. اوكي alright very good. احنا لسه الصبح ولا احنا بعد الظهر؟ لا تمام. يلا صباح الخير. احنا لسه الصبح. يلا جود مورنينج. صباح الخير. وعشان نتفق اكمو والبي انيشيشن والبي رايت هارت كاثيترايزيشن. ما تقوليش اكمو باكمو. اوكي I'm just kidding. يلا we'll start the ECMO initiation. Merry Christmas of course and happy holidays. I thought to be Christmassy today, so Merry Christmas to everyone. The ECMO to initiate, I will start it, of course, by initiation of cardiogenic shock. So touch of the golden hour that Dr. Mayada had mentioned. So multi-dimensional phenotyping cardiogenic shock, you're working on all the layers. So I'll just like put all what Dr. Mayada presented in all together and how to look at the patient multi-layer and dissect and phenotype. So the golden hour, as she mentioned, is very important, powerful in all the mortality data that we had. Early identification of cardiogenic shock is crucial. Standardized shock team, and they will like have some comments on what Dr. Mayada had presented. And then the adequate monitoring, of course, like you're monitoring the patient with your echo, with your PICO system, preferably with Swangan, just kidding, with or the PA catheter as well. Just the hemodynamic monitoring is very important. And then the etiology. So AMI shock, heart failure shock, congested shock, non-congested shock, cardiometabolic shock, and cardiorenal shock, RV, LV, and BIV shock. So you're already computed all this with the sky staging A to E that you all know, and the hemodynamic monitoring as well. The machine learning had helped us tremendously in phenotyping the cardiogenic shock and then how to initiate the MCS after this, but this is the phenotyping part, recent publication. So non-congested cardiogenic shock is equal in heart failure shock and AMI shock. And then the mortality rate is lower, it's 10 to 28%. So when you're having non-congested patients, of course, like we treat them golden hour and everything, but their mortality is lower and they're equal in both phenotypes. The cardiorenal shock is higher in the heart failure cardiogenic shock more than the AMI cardiogenic shock. The mortality start to increase a little bit. So I'm seeing some a little bit creatinine, BUN is high and all these things. So mortality is a little higher, 27 to 45%. And it's more in the heart failure cardiogenic shock more than the AMI. Cardiometabolic cardiogenic shock, when you're having higher liver enzymes. So AST is high, ALT is high. The mortality is actually the highest. I just had a patient in-house who was the brother of a patient who ended up with an LVAD, and then he's coming in with high kidney functions, high liver enzymes and all that. And the document in the note from the younger doctor who admitted him was the patient is warm and wet. So it's very important to know that this patient was actually cold, coming cardiogenic shock. He had the higher liver enzymes, higher kidney, bad kidney functions, or like started to be worse kidney functions. The mortality is very high, 52 to 56%. My patient ended up on ECMO and an intra-aortic balloon pump in 2 days, but we missed the golden hour. So that's that. And then the cardiometabolic shock happens more with the AMI shock. So it's double hit with the AMI shock more than the heart failure cardiogenic shock. And the mortality is highest. They are not mutually exclusive. So the machine learning will help us in identify association of pathologies, will help us in improving understanding of cardiogenic shock and pathophysiology, provide additional independent means for risk stratification in cardiogenic shock, estimation of treatment responses, which will be great. We talk about this all the time. Retrospective re-evaluation of the data that we missed, focusing, including and re-evaluating specific phenotyping when planning prospective trials in the future. So this is a recent publication for phenotypes, but they looked at it from different perspective and they did it three-dimensional classification. So they said non-dilated LV, dilated LV, RV dysfunction, older age, mild LV dysfunction, severe kidney dysfunction, marked hypotension is from phenotype from 1 to 5. And then they plotted it three-dimensional with the sky staging again is the mortality. And it was beautiful actually. So they said the phenotype 1 with the sky stage A and B, C, D, and E. The mortality in the phenotypes, and this is what I will add, I selected some slides just to be complementary to your talk. The mortality in phenotypes, as I mentioned earlier in the machine learning slide, non-congested shock is the lowest, cardiorenal shock comes after this, and cardiometabolic shock will be the highest. Cardiometabolic means that the ALT, AST, the liver enzymes are high. So that's that. Like it's in different classifications also and different studies. So the mortality for the heart failure cardiogenic shock, like this is how the distribution. First, the mortality in the AMI cardiogenic shock is way higher than the heart failure cardiogenic shock. So AMI shock is mean, right? Is more mortal than heart failure cardiogenic shock. But this is interesting. So ECMO, that we'll talk about more today, still have high mortality in both. And then ECMO plus an intra-aortic balloon pump, even more mortality, adding 1 MCS. ECMO with Impella CP more, but ECMO with Impella 5.5 is way lesser mortality, which is interesting. Of course, you're looking forward and waiting for more data. Hopefully, we'll participate in influencing the literature by providing our data and be PI on the studies and all these things, but this is interesting. Of course, ECMO plus 2 MCS, the mortality goes back up. Two interesting phenotypes that we're talking about them, Mandib Mera and the cardiogenic shock work group talking about it more these days, the inflammation and cardiogenic shock. So heart failure, cardiogenic shock, they're finding some of the inflammatory mediators, but I will also say that the MI cardiogenic shock has an inflammatory influence. So do not be surprised if you're having an AMI shock and also lower SVR, inflammation, because it's source of systemic inflammation, hypoperfusion, myocardial injury, or microcirculatory dysfunction. And then the inflammation will happen. You have pro-inflammatory markers like interleukin-6 and TNF factor alpha, angiopoietin-2, together with the degradation products that are coming from the poor perfusion of the organs can lead to a mixed picture of cardiogenic shock and systemic inflammation. Like the other way around, you can have a phenotype of inflammation in the blood affecting the heart, like in the autoimmune, for example, to look the same under the microscope, this lymphocytic infiltration, just like rejection in our transplant world. Also viral myocarditis, fulminant myocarditis, acute myocarditis will look like that under the microscope, or immune checkpoint inhibitor myocarditis. Different subphenotype is the eosinophilic myocarditis, inflammation affecting the heart, but this is the eosinophils because they have pink cap. So very steroid receptive, and also there is a specific interleukin-5 antagonist called mipivumab and MIPO, and this treats the eosinophilic myocarditis very well. I have a patient actually in the outpatient setting taking it, and excellent outcome. Rare, of course, and this is the scleroderma or the microvascular. I had one patient. It's in press. We're publishing the case in JACC case reports. So the scleroderma myocarditis, this is the microvascular fibrosis there. So scleroderma and affecting the heart. The patient passed away. And this is the multinucleated multinucleated lymphocytes, which is the giant cell myocarditis. You can see some inflammation, of course, will not distribute, will not differentiate any of that on the FDG PET, CT PET, and also T1 fibrosis, T2 edema on the cardiac MRI. The hemodynamic effect, like as Dr. Maeda said, like we have a hemodynamic effect and we have a clinical effect. The hemodynamic response is important and the clinical response is important. So you are treating, phenotyping, dissecting the patient, thinking multi-layer, and while you're treating the patient, you're monitoring the hemodynamic response. You want good blood pressure, good cardiac index, unloading the RV and LV, very important. And the clinical response, improving the lactate, improving the kidney functions, the base deficit, the liver enzymes as well, and the kidney functions. This is the four fronts. I like this slide a lot. The four fronts of the cardiogenic shock. This is how you fight cardiogenic shock على الأربع جبهات, على four fronts. So basically, you have circulatory problem, ventricular overloading problem, coronary perfusion problem in both phenotypes, and renal and hepatic problem as well. So you want to think about these four things and monitor them and treat them. So you need good blood pressure with the circulatory support. You need to unload your both ventricles either with diuresis or with mechanical circulatory support, monitoring the VTAC and BNP, monitoring lactate and creatinine. You want to perfuse the coronaries and always think the coronary is equal to the perfusion pressure inside the coronary minus the LVEDP, minus the left ventricular and diastolic pressure. And this is how the blood flows in the coronary. So in AMI and non-AMI cardiogenic shock. And the same concept with the kidneys and the liver. The blood flows from the mean arterial pressure or the perfusion, the arteries, minus the RA pressure, which is the congestion of the organs. This is what I was saying, just like interpret the waveform very well. He gave an excellent lecture about PA catheter, but just make sure you're interpreting the waveforms very well. So you have ECV waveforms that are reflecting the RA, the RV, and the tricuspid valve. ECV waveform that's assessing the LA and the LV and the LVDP and the mitral valve. This is the pressure volume loops in the atrium. So basically, like you have like the A wave and the X descent, V wave and the Y descent. And then if you have stiffness or MR, as we were talking yesterday, you'll have a huge V waveform and peak V waveform that will affect your hemodynamics. And this is the mechanism. I just mentioned it yesterday, so I thought to put the slide. The mechanism of the V waveform, always remember that the RV is filling the LA and the LV is filling the RA, and this is what's happening during the filling of the atria, hence the V waveform. So if you're having stiff ventricle, you will have a very high V waveform. If you have MR or TR, high V waveform. The management, so we're going to ECMO, right? But we have to remember the medical management of cardiogenic shock with the pressure volume loops that we all love, again. So this is the LV pressure volume loops. We talked about the RV pressure volume loops and the LA pressure volume loops. So basically the power of diuresis, unloading, very, very important concept of the LV. So we are moving on the end diastolic pressure volume relationship. That way, you're decreasing the preload, you're also decreasing the afterload on the same end systolic pressure volume relationship. Sorry for touching this tree. And then the positive inotropes, you are moving the whole elastance or the inotropic curve to the left. So you're increasing the stroke volume that way, and you're increasing the cardiac output that way. And then the afterload reduction is beautiful, because the afterload reduction, if you have reserve in the blood pressure, you are decreasing the pressure against which the aortic valve is opening, and hence you are increasing the cardiac output without decreasing the cardiac work, and this happens with vasodilators. So this is the stroke work, which is the area under the curve and the potential energy. And when you're having an inotrope, you're actually increasing linearly the PV area, the pressure volume area. So you're increasing the myocardial oxygen consumption. And the inotropes are great, will give you good cardiac output, but remember, they will also increase your oxygen consumption as well on the cardiac work. So we have to think when we are going to wean them. As you see, increased contractility will just push the line all over and the elastance curve to the left. This is the Innova algorithm. Actually, my friends Shashank and Tahrani, Shashank especially, because he interviewed with me, and he has the algorithm of Innova. Create your own algorithm, whatever. I always encourage any center. If you have nothing, if you have medical therapy, balloon pump, just create your own algorithm. Even if you just have one thing, balloon pump, cardiogenic shock trial proved that it doesn't have benefit in shock. I do not believe that completely. The RCT is very hard, the randomization, and the mechanism is always influential on this. If you have AI, the balloon pump is not a good choice. If you don't have AI, even in AMI, non-AMI cardiogenic shock, you're in inflation, in diastole, you are perfusing, and then you are perfusing the coronaries, perfusing the distal organs and the coronaries, and you are unloading the heart. It's very hard to calculate how much the balloon pump will actually give. In the States, they always, the balloon pump will just give you 0.5 liter, 1 liter. I don't think so. Good. Collaborative model that Mayeda had mentioned. So you have a shock doc, and the shock team usually is comprised of a surgeon, critical care, interventional, heart failure cardiologist, talking amongst each other, and shock coordinator. You can pick a nurse to have to be a shock coordinator. And then the tertiary center are calling you from outside the hospital, but you also coordinating the shock in your own center, and you're having a hub and spoke model. I created it twice, thank God, in Kansas University Medical Center, in Pulse Heart Institute, and both institutions benefited dramatically from creating cardiogenic shock. I'm sorry. Sorry, slow down. Slow down. Okay. Good. So this is the collaborative model for shock. We have cardiogenic shock. We have many MCS. You guys will talk about the unloading. You talked about the Impella. We talked a little bit about the intra-aortic balloon pump. And VA ECMO will dissect a little bit on when to initiate. So from the data standpoint, we talked clinically and we talked PV loops, but Amr loves data. He gave me this input, so we'll go through the data a little bit. You have central ECMO. Hatem will cannulate the central ECMO, right? The RA and the aorta and all these things, and the peripheral ECMO with different configurations, VA, VEV, VVA, whatever configuration you will look at. So time for VA ECMO, when it's not too late, basically, right? This basics, not too late, not too early, because ECMO, we want to avoid it. It has tremendous amount of complications, vascular complications, hemolysis, the patient can't move. It's very mortal and morbid, more than mortal. When there is an appropriate indication, of course, there is a tight selection process. So there is shock team, there is a surgeon involved, intensivist involved, and even the patient and the family is involved in like putting the ECMO, because it's a big decision. When there is an entrance and exit strategy, so people talk about exit strategy, bridge to transplant, bridge to LVAD, bridge to recovery, but also the entrance strategy is very important. Like which arteries we're going to cannulate, and central versus peripheral, and all these things. Resources to support the care. You are in a good center, you have nursing, you have infection control, you have all these things. Technical skills to perfuse, perfusionists, cannulate, surgeons and intensivists, and heart failure docs, decannulate, vascular, and deal with complications. ECMO program, so ECMO program director and coordinator, and all the requirements for ECMO program, and patient family involvement. Even if it's ECPR, it's a big deal. It happened to me many times, and I go aside and, wow, we are putting this and that, and my husband or my son would never want that, so just stop. Good. So VA ECMO bridge, VA ECMO bridge to recovery, long-term assistance, or heart transplant, and of course it's a shock, high mortal condition, so patients can die. When to implant the ECMO, the basic indications of cardiogenic shock and inadequate perfusion and all that, and the patient has some volume, has some blood on them, so we're circulating something. The indications, or the popular indications for ECMO, we have like AMI, cardiomyopathy, post-cardiotomy, and the list of things that you all know. But we looked, the most popular explanation and percentage for ECMO is an AMI, dilated cardiomyopathy, and post-cardiotomy. And then the others will be like lower refractory out of hospital cardiac arrest, late graft dysfunctions that we don't like to see. And then unfortunately, PGD, myocarditis, and pulmonary embolism, refractory shock comes after the AMI and dilated cardiomyopathy and post-cardiotomy. One of the newer publications, so timing of initiation of ECMO with cardiogenic shock. There is one in the American Heart Association and one in the European, in the European journal. And of course, the results are very predictable, right? The US people are more aggressive in MCS. So basically, the study was good, actually. Like they had the multi-central, they had a large cohort of patients, they excluded ACPR, and then they excluded some other patients when timing and admission was 96, so there is other MCS. And they left with a high number of patients that they enrolled, so good study design. And then they found some outcomes that are interesting. So cardiac arrest or non-cardiac arrest preceding, of course, cardiac arrest, higher mortality, statistically significant if you are initiating the ECMO less than 24 hours versus more than 24 hours. This is cardiac arrest versus no cardiac arrest, and then one pressor versus low pressure. If you initiated ECMO early, 0 pressors, the outcome is, or one pressor, the outcome is a little bit better. Especially in the early 24 hours, it was statistically significant. And then they plotted the in-hospital mortality for earlier versus later in the 24 hours. And of course, the SKY staging, BCDE. And when you are actually applying ECMO earlier, in the first 24 hours especially, statistically significant that the outcomes are better. So those are the patients is like, do you really want ECMO? In them. And they're like, they're not that sick, So the overall non-cardiac arrest and the cardiac arrest was the highest mortality. No cardiac arrest was the lowest mortality, and the overall was there. The outcomes are better when you are putting ECMO in the lesser than 24 hours or early in the disease process. And this is like the mortality is higher with time, and the survival is better with time when we are plotting it in another curve. So that was the conclusion. Longer delays from admission to ECMO initiation were associated with a higher mortality rate in a larger scale international registry. Their analysis support optimization of door to support time and the avoidance of inappropriately delayed ECMO initiation. The other trial was the European one, the timing of VA ECMO in patients with cardiogenic shock. Again, good trial, and they included even Ecpella and Ecmella. So basically, Ecpella is the ECMO and Impella in different arterial punctures. Ecmella is ECMO and Impella, but it's a V connector. So they're using the same arterial puncture, Ecmella, Ecpella. So they included this, and they did like the early MCS, intermediate MCS, and then delayed MCS. The implementation within the first 24 hours onset was not associated with a 30-day mortality. And they said more trials were needed. They dissected a little bit in some patient-related things, and they found out that there is some patient-related conditions that can have higher likelihood of delayed MCS versus early MCS. And then this is their, like, you know, the outcomes for like no CPR. With CPR, the same thing, but they found no statistical difference between both ECMO and ECMELA. This is an older trial, the ANCHOR trial, and this is like before the era of the microaxial transvalvular pumps, which is the Impella, and the ANCHOR trial like decreased the mortality decreased significantly in AMI shock if you have intra-aortic balloon pump alone versus ECMO. One case that I will go through, it's an interesting one. So 32-year-old male presented to outside hospital. This is the beauty of the hub and spoke model, right? And the retrieval, the ECMO retrieval. So in outside hospital, shortness of breath, fever, and influenza A, they called us in order to go and retrieve this patient on VV ECMO, not VA ECMO, VV ECMO. So our colleagues went there. Ihab, your friend, went there and he assessed the patient and he's calling me and he's saying like, hey, the ejection fraction is 20%, the lactate is 11.8, the troponin is 6.4, we don't have a coronary angiogram, we don't have time. So we decided together that he will go with the VA ECMO first. So he put the VA ECMO and still the patient is tremendously hypoxic. So he's severely hypoxic. His blood pressure was okay, perfusion is okay, but he's hypoxic. So he decided to put a Y connector and to feed the RA with oxygenated blood. So he converted him to VA ECMO. I told him on the way, give him a gram of solumedrol. I didn't know. I assumed that this is a non-AMI shock and maybe myocarditis because influenza A and all the sequelae that he had from the congestion, lung congestion, all these things. Because they're saying the X-ray is white out. I will show you. So he did this successfully. The patient was perfusing better and also the oxygenation is better. So he decided to transfer him to our hospital. So when he came to the ICU, this was the echo. Yeah. So severe, like he's in ECMO, flowing 4 liters, whatnot. The AV ECMO rested on it, oxygenating well, but the RV and the LV is not moving and the aortic valve is not opening. Spontaneous contrast is there. My intensivist was like, should we give contrast to rule out LV thrombus? He said, there is enough. There is enough of it. Other views, the mitral valve was opening, thank God, but there is no clot. Like I went with my TEE in and out. I did the TEE myself. So I went in and out. There are many other pictures, but I show you this and got the long axis, short axis, and everything. If I leave him, there will be clot, but at this point, there is none. So we activated the shock team. We had extensive discussion with the surgeons, the interventionists, the intensivists, and we decided this. So we decided to activate the cath lab, talk to our interventionists, do right and left heart catheterization, leave in the swan, and if the coronaries are normal, like it's not an AMI shock, to get an endomyocardial biopsy while in there, and put a microaxial transvalvular flow pump, Impella CP, because we didn't have time, and we decided that we will put it femoral. We'll not go and get a cut down, or we'll do axillary area of the fanciness, we'll do it quickly, femoral. We already gave him the high-dose steroids, but I'm thinking in my mind, like a transplant cardiologist, of course, I can't help myself about immunosuppression. Like further, if the patient is not steroid responsive, what I will give him, like Thymo or Plex, IVIG, and all the other medications that MMF and tacrolimus, immunosuppression. So that was his lungs, white out when he came in, white out. You see the poor Impella CP is not even visible because of how the lungs were so congested, cardiogenic and non-cardiogenic pulmonary edema. Because we found that the wedge was 25, but was not explaining that much. It was influenza A, pneumonia. This is after like 2 or 3 days with diuresis and mechanical ventilation and the VAV ECMO. And then this next day, like immediately, this is the echo next day. So we found out that this like spontaneous smoke and all the things that were happening in the original echo is not there anymore. Thank God there was no LV thrombus. And the RV, of course, this is the RVOT, but started to have some life in it. The patient's still in VAV ECMO, Impella P4, and resting on it. So the Impella here is, yes, unloading the ventricle, but is acting as an LV vent. So we are flowing the Impella just 1.5, 2.5 liters at most, so it doesn't get the deoxygenated blood, which is oxygenated in this case, but traditionally the deoxygenated blood from the LV, and then do Hilrichian syndrome, the north-south syndrome, or mixing. So that happened, and then by the 3rd day we were weaning. The LV was recovering like this. We give him high-dose steroids. I didn't need to give him any of the Thymo or all that. We did the biopsy. The biopsy came handy. Right now we know Is the patient has eosinophilic myocarditis, giant cell myocarditis, or just lymphocytic infiltration? Most likely viral myocarditis fulminant. Some of the lymphocytes were still there, and necrosis. So confirmed lymphocytic myocarditis. And then we weaned down the impella, we weaned down the ECMO in one study, and we found total full recovery of the RV and LV, and the patient did very well, and he was decannulated from both. Finally, the VV ECMO was the last thing that came out. So we first decannulated the VA ECMO, and then the impella, and then the VV ECMO, and then the mechanical ventilator. So some independent predictors of ICU death from ECMO under CPR, prothrombin activity less than 24 hours, 24 urine output. This is the independent predictors in mobile ECMO. So basically not too late. Complications percentage, which is like, again, it's very high morbidity, but this is basically to summarize and give you some an idea of the percentage of the complications: major bleeding, femoral vein thrombosis, arterial ischemia, vena cava thrombosis, surgical wound infection, and overt pulmonary edema, which is a big deal. Overt pulmonary edema means that the heart is not unloading itself. You're not helping the left ventricle, so less likelihood of recovery. It defeats the purpose of unloading that you guys will talk about in the next lecture, I think. And stroke, of course, cardiovascular complications. So who's not a candidate? Irreversible myocardial dysfunction, patient contraindicated for heart transplant or long-term assistance, no exit, chances of survival is too small, patient and family preference, or the surgeon said no. And that's that. Thank you guys for listening.
Pretty nice talk. Multiple considerations for our settings. Obviously, the transplant exit strategy is not there, so that's a big part. That strategy is very limited. If you have like limited amount of devices, you want to be very selective, and you cannot. And there are no enough devices available for everybody. And then it's very, very clear that early ECMO is much better than late ECMO. But this is intuitive. However, the point that is not very clear is it early ECMO or no ECMO? Because then if you say no ECMO, then it becomes late ECMO, and then that's it. And if you have, again, limited number of devices, very cost constraints, because if you put ECMO on everybody, probably the survival will be better. The ECMO complications will be more, but the survival will be better. But then, would you do that?
Yes, no, excellent insight.
If patients do not need ECMO and then you put them in ECMO, they will eventually survive. However, did he really need ECMO or not? And then if he doesn't, then he becomes a late ECMO and then he dies. This is
excellent insight. And like we are in the same boat. I'm in a center that has transplant and VADs, and then put ECMO on everyone and all that. But I really think the same way, because the complications are very high. And yes, you don't want to miss the window at the same time. I think the very simple answer to this is multidisciplinary team. Like, it's a discussion that we all put our heads together, tailored to the resources that you're having. This is why I mentioned the resources, the entrance strategy, the exit strategy, the care for the ECMO and the ICU, and knowing your limitations and knowing your expertise. You're working at the top of your license, but also you're knowing your limitations at the same time. If we reflect on the data alone, I would say the power of like the golden hour in intervention with medical things and univentricular support. Someone mentioned it. Univentricular support is very important. Even at Saltas in Cleveland, Ohio, we're just like in our enterprise meeting, and he's big about univentricular support. And we have intra-aortic balloon pump till proven otherwise, the power of unloading. But it's all about involving everyone quickly in a phone call and implementing this very quickly early on. This is what we need early, because it will become late phone call. I think it's the recognition. We are facing huge problem in the States, in Abu Dhabi. I assume here, I haven't worked in Egypt for a long time, but I assume here that the recognition is lacking. The patient might come late, but we recognize him also late. I just, like while I was talking quickly, sorry, that a patient came, he was like clearly hypoperfusing, cardiometabolic shock, cardiorenal shock, biventricular failure, and he might have needed balloon pump at the time. He just like it was clearly documented, and the data that my team had received was the patient is warm and wet, big, huge, and my fellows in Kansas, like big time. I don't blame him. It's our involvement, education, of course, and our involvement and reflex for having low threshold to get everyone on one phone call and someone to cover that.
Available tools. Congratulations for your case. Really, really good management. However, if there's no impeller, a vent would not have decompressed that vent. And so you really need like an LV vent to be able to do this. Like in surgery, we put the vent inside the LV cavity and then you decompress it. However, if you do the percutaneous and you stay and then left atrium, this LV would have not recovered because it is very distended, and then you get no coronary flow, and that's the end of the day. So again, having like appreciating what tools you have, having a clear exit strategy for that really determines which patients would actually benefit from going further, because whenever you have more tools, you start using them, and then if you do not have an exit strategy, you wouldn't.
Yeah, 100%. And I actually see the opposite thing. Like everyone is in ECMO, everyone receiving this and all that. You resolved the debate between me and Amr about the lava ECMO in this case, because I presented it to him and we discussed and didn't escalate that much, but we thank you.
Lava ECMO will be the cabin recovery is poor, it is very demanding, and how are you going to escalate the treatment? They used to escalate the treatment from ECMO to Ambella. Now you are complicating the case of not recovery.
Yeah, like alternatively, like in this case, I would have, like, if I have ECMO and balloon pump, I would have put them both with early immunosuppression, because he's clearly responded to steroids even on the way. Like the lymphocytic infiltration was there, but it was not that bad, you know. Because the biopsy was done like 12 hours or 14 hours after like receiving this, so maybe he started to clear or something like that. Just like the eosinophilic myocarditis case, like the follow-up was totally clear. EF recovered 100% with the interleukin 5 and with the immunosuppression. So I think also the power of medical management. And then like if I don't have this, I will use that. I will not like focus on what I don't have. I will focus on what we have. He doesn't have AI. Balloon pump might have like pushed a little bit of the distal organs and decongested him a little bit with the ECMO. But I agree with you, opening his chest would be drastic. And the best thing is just like save this LV from a clot, because otherwise this LV would have clotted with the ECMO high afterload. And then
very high EDP would
exactly 100%. Thank you so much. This is what I was trying to say, and he's saying it in a better way, in the coronary perfusion and the relationship with the LVEDP, but also the science behind like the door to unload paper I mentioned, which is the molecular biology of the law of Laplace. So the high tension equal radius times the pressure. So you have a very high LVEDP times the radius, the LV is distended. You have very high tension on the myocardium, less likely to recover. So it's two hits, the coronary hit and the tension on the myocardium. Molecular biology had proved that you are losing myocytes, you know, for this. So double hit. This is the thing about Impella. I think everyone, like if the technology is there, so it should be disseminated in the world. Just this, you know.
There's no enough data, or at least not very supportive, maybe with the danger. However, conceptually, the Impella looks really good concept, because you really unload the ventricle, you get the best perfusion. If you do not have a respiratory failure, you just get the thing done. Maybe not enough data to support this concept, but definitely much better than the intraocular balloon.
Yeah, no, yeah, and I think the data will come like for one study to make the guidelines to be class 2A indication is huge. And it was good study. I think they were like with the cardiogenic shock low, and we're collaborating. We're collaborating with Naveen Kapoor in the shock conference. God willing, we'll get like we can put together a nice cardiogenic shock group together, you know, and then we can maybe make a cheaper Impella or like a local Impella for real. And the third thing that we need to collaborate on, we need to make is an LVET completely implanted in with no driveline.
Yes.
Yeah. Done. Done.
The first step would be transcutaneous power, but then eventually implantable battery. Yeah, he would say, yeah.
Yes. Yes. This is why I wore the same color.
And a lot of things have been passed. The patient is first of all already right hand surgery and some from maternity as well. And the patient and the clinician is here, the cardiac surgeon is there. Everything is ready, but when you are going to set the ECMO for patient post-cardiac shock, and when you get and what is and go through your experience through all the image strategies.
Yeah, I intentionally didn't put the post. Intentionally. So the post-cardiotomy part. Yeah, and we will get, inshallah, like seriously, we'll get the virtual thing for the shock. We have a big post-cardiotomy talk, Scott Silvestri, and the chairs are very strong, Mitisha as well. So a little bit of my experience post-cardiotomy, given that I spent tons of time in the OR talking to the surgeons. In my previous institution, we didn't have cardiac anesthesiologists. I was talking to them. So they were relying on the heart failure cardiologist to go to the OR to help with the VAD management, and then also to get the patient off pump. So I will just speak a little bit from this experience. So like the easiness of like it's a collaboration between everyone and the cardiac anesthesiologist. I think like cardiac anesthesiology consultation in the OR with the heart failure docs will be very healthy, right? I think they will be able to get good input, good insight, because they take care of the patient after this in the ICU and outside. The timing. So again, it definitely depends on the surgery, but you want to unload the ventricle as much as you can. And not to put a lot of high afterload. Meanwhile, you want to perfuse, right? So multidisciplinary in the OR shock call, which is the surgeon sometimes resistant for this, right? Right? Of course. I mean, all over global. I don't think Hatem is, because he's here, but but really like making. This is what I was exactly talking about. So multidisciplinary management with this, right? Maybe this patient needs diuresis, you know, in the OR, which the anesthesiologists are and this is done. This is done, right? And then like all the indicators right there. You want to avoid really. This is like early versus late implantation of the V ECMO. Here you want to avoid ECMO because you solve the problem, and the longer pump run the patient will have with the ECMO and the higher afterload the patient will have will affect the patient more. One thing that is like I have experience with and saved us tremendously in getting the patient off pump after multidisciplinary conversations, trying to avoid ECMO as much as you can without losing the timing is perioperative and intraoperative use of Impella 5.5. To be honest, I built the platform, and then many cases that we would not even take to the OR, and you're having severe AI, and the patient doesn't have any exit. The EF is 10%, 15%, and the LV is 7 centimeter, contraindicated by guidelines to do AVR. You will put home on pump, they will get pump run, they will get out of the OR, and they're on ECMO, and then on rocket fuel of epi and nor-epi and all the like kitchen sink of the medications, they will not survive. So the logic says, do not take these patients and be in the situation. So selection is one of the things to and then
talking about an ECMO after post-cardiotomy, that is preferable. You're not putting the central ECMO choice.
Yeah, absolutely. So I was assuming I was talking about both. I was talking about central ECMO too. Yeah. Good. Like you're still, like, where are you cannulating? You're just like not, you're still cannulating outside of the ventricle. Like if he's cannulating the ventricle, it's different. But usually you're cannulating the aorta.
That concept that the direction of blood flow, but it depends on the pressure though. Because on peripheral ECMO, the blood flow goes backward. Or in the central ECMO, it is enlarged. However, what matters for the ventricle is the opening pressure of the aorta. So the pressure of the aorta is still high. So the afterload is still high. So you have to unload the LV, and just putting the cannula in the ascending aorta rather than the femoral does not cause unloading of the LV.
Thank you. I assumed we're like, yes. 100. So central ECMO, peripheral ECMO. So but mainly I'm talking about central ECMO. This case, unless you're having a venting strategy, but post the impella directly in the aorta or supraclavicular or subclavian, you can plan your procedure. You can get the cut down first, put the impella, do your valve, and then put the impella through the valve, and the patient will come out with an LV unload, not pump run anymore. You can give him GDMT, then him or her GDMT the day after. You just can't put a mechanical valve. So a lot of it's a huge topic, and we can talk about it for a long time. But this is my 2 cents on it. Oh, and we just actually we had a rejection case, acute rejection, which we don't see often, but we just had a patient with acute rejection AMR, not ACR, which we'll talk about tomorrow, inshallah. So cellular rejection, he was antibody-mediated rejection early on. So the patient arrested. While I'm doing the TE, I was on TE that day, not on the service itself. So I was doing the TE, and once I put the probe, it was like cardiac arrest, but he was in peri-arrest anyway, and we opened the chest bedside. We did CPR like this and cannulated like centrally bedside, and they was very worried about the graft because this is transplanted heart in a young patient, that the graft will fail because of high afterload. But thank God the LV was venting. This is my words, venting itself. So there was contractility. The patient came back, and immunosuppression and plex and IVIG and all that. And after this, the graft came back because the transplanted heart is coming from someone who is very healthy, and it was venting itself. So we don't need an LV vent at that time. But huge, even in central ECMO, it's big concern that the LV might not recover because of high afterload as well.
ده البيج ايشو عندنا، يعني ممكن العيان يتحسن يبقى امبروفد وكل حاجه والبرفيوز ويل وين الفارماكولوجيكال نور ابنفرين فازوبريسوس كل حاجه رينال وايز امبروفنج ستيل اكيد ليفر سيفتي doesn't improve. What is the intervention from your experience?
Yeah, like usually the liver enzymes lags after that. So like the AST comes first, ALT, and then the bilirubin lags a lot. But if really patient is decongested and has and perfusing well, the liver enzyme should improve. It lags. Oh, it lags. That's absolutely, and we tolerate that, and that's fine from my experience, not data.
It goes to 30s.
30s, yeah, and it peaks and then it comes back. I don't know what's your experience, but like
We did
Yeah.
but it's bilirubin going up, not going down. Sometimes going down few days, then it comes up again.
Yeah. I dive in the reason, like if it is only heart failure, it will lag and come back. Bilirubin takes time, but there might be something else going on, and cholecystitis as well. Like when I see bilirubin high, I dive and I do all my check boxes, even if he needs RCP or MRCP or whatnot. Just like make sure because the patient is having stasis and all these things, and sometimes they develop this and the sinusitis of infection that we commonly miss. This is my ICU background. That's why I drive the ICU people. Like they like me, but they hate me at the same time. And so long as they have this and that, مالكش دعوة. أنت مالك أنت. Like perfusion and decongestion, and work up for the hepatology part, like the isolated liver part, and then it will come down. If all this checked.
About this case, if a patient didn't improve on the
Yes. Yeah, thank you. Yeah, I love this question. I transplant cardiologist, so I love that. Of course, I will go to thymo, right? I will not hesitate. Improvement, I will label him like I will wait to the second day, right? I have support and the patient's alive and all this, but I would be very aggressive. I don't have support, and the choice that I will choose If it is like, oh, on the borderline, I would choose Celcept, something like mild. But if the patient is really not responding, I'll hit him with ATG, with Thymo. Just empirically? I don't know. Maybe. Because I will not know what I'm treating. Is it giant cell, or I can assume things? Yes. No, I can assume things. But
You don't have
of course. And if I have very high index of suspicion without the biopsy, I'll still go with Thymo. Celcept is the milder thing, but don't forget to do the prophylaxis. The Bactrim, the prophylaxis for PCP and for VZV and for the viral part. Is it? If I'm hitting him with Thymo and all these things, I will give prophylaxis. No, I will not. Yeah, because if you get any opportunistic infection, this patient will die. And they are not randomized, for sure. And then Plex, the Plex and IVIG also I will think about it, like the filtering the immunoglobulins, and this is what we did for our AMR patient who had no other option. Good.
مش هسمعنا غير بالمايك ده.
دكتور محمد
مش هسمعنا غير بالمايك. دكتور محمد امين استاذ كريتيكال كير في شريف مختار كان موجود معانا على الزوم، كان عايز يقول كومنت، انا مش عارف هو موجود ولا مشي بقى. كان كاتب السؤال من ساعه الرايت هارت كاس.
دكتور عمر، ازي حضرتك يا باشا؟
اتفضل يا باشا.
لا والله انا مستمتع جدا وبشكرك، والله الواحد استفاد واتعلم كتير قوي في الورك شوب ده. بس انا كان عندي دايما كونسيرن على الادفانسد هيمودايناميك مونيتورنج تولز وايل يوزنج الميكانيكال سيركيلاتري سبورت، لان النورمال فيسيولوجي والنورمال دايركشن اوف فلو اختلف تماما. فهل انتوا في اكسبيرينس معينه؟ انا عارف طبعا ان احنا بنعتمد على الترند، بس هل انتوا في اكسبيرينس معينه ان سيرتن ديفايس عشان نقدر نشوف نفرق الكومبوننتس بتاعت الهارت فيلير والهيمودايناميك يعني while using different mechanical circulatory supported device؟ يعني مثلا الفينو ارتيريال اكمو هيبقى فيه ريتروجريد فلو، والالفاد هيبقى الفلو كونتينيوس، فالثيرمودايليوشن مش هيبقى اكيوريت قوي. فهل احنا في حاجه معينه مثلا في الهيمودايناميك مونيتورنج ديفايسز preferred while using these devices؟
deep question. yes. اكيد هيكون في حاجات تailored حسب الديفايس نفسه. فان ذا اكمو احنا عارفين الاكمو هيكون فاوند النمبرز بتاعتنا تماما. مش هنقدر نعتمد على الار اي، مش هنقدر نعتمد على الويدج عشان في اوريدي ذا ار في از اوريدي ديكونجستد، ومش هنقدر نعتمد على الفيلينج بريشرز بتاعتنا. فاحنا عارفين ان الداتا اللي بتديها لنا الاسوان at this time and we have to use other data. We are using the art line, we are using the post oxygenation and blood pressure, and the perfusion indices and all these things. In devices like intra-aortic balloon pump, we rely on the augmented map. We are not relying on the art line map. We're relying on the augmented map. However, still the data from the SWAN is there. The intra-aortic balloon pump, this is something I manage sometimes without SWAN. And relying just on the augmented map and the end organ perfusion and the echo and all these things, giving no aortic regurgitation. Always look when you're putting balloon pump, if there is, because it will tell you in the literature. Sorry, I got out of the question. If it tell you in the literature there is mild AI, the mild AI is not a contraindication for balloon pump. It's just counterintuitive. Because عشان الانتراورtic balloon pump had push the blood in systole, will inflate in systole, will push the blood through the aortic valve, will make this mild, moderate, or severe, and then increase the LVEDP, and then just like will be counterintuitive. So that's that. And then for the Impella, and actually the Impella has not FDA approved, but have some parameters on the Impella itself, like on the console itself, that will make some calculations partly reliable. Hopefully we'll get FDA approved. Will give you LVEDP, not by direct measurement of the LV, by calculations. Will give you map, and will give you how much actually the heart is doing, the native cardiac power. For the LVAD is like, if you are managing it medically, you're relying on the map through the Doppler. If you're putting Swan-Ganz, the Swan-Ganz is totally reliable at this point. The later one. The later one.
Thank you very much. Thank you for your answer. Thank you.
احنا هناخد ريست ربع ساعه صلاه الظهر احسن ونفتح. شكرا. ناخد بس بريك ربع ساعه بس نصلي الظهر والبريك موجود.